We're welcoming our last passenger, but without whom the train will not depart. And this is Aniek Schouten. Aniek is a researcher in health economics evaluation at UCMC Utrecht. She's also a part-time PhD student on methodology of conducting health economic evaluation alongside multinational trials. So she will tell us how to conduct economic evaluation, health economic evaluation analysis in DCTs.
Thank you. Yes, last but hopefully not least. Indeed, I usually do health economic evaluations, so that's a little bit different of the work we did here. A little bit out of the comfort zone, but luckily I had a really nice group of people to work together with. And I think we provided some really nice economic insights into what are costs that you have to think about when you introduce decentralized trial elements. And we used a radial trial here as a case study. We used a mixed methods approach, and we specifically looked at the costs associated with clinical trial personnel, study sites, third-party service providers, and this big bucket of other costs, where we looked at cost drivers in the setup phase, recruitment, and follow-up of the trial. Here you see a really large, overwhelming picture of all the costs that we found for the different phases, so setup, recruitment, follow-up, per conventional, hybrid, and remote arm. And in yellow you see the standard operational costs. So in radial, the decentralized elements were not just allocated to one of the arms, but spread over different arms. And those are shown by all the other non-yellow colors. And what we found for total costs in the radial trial, the main cost drivers were the development of a trial-specific central study platform and smartphone applications, which this isn't just the development of this platform, but also the integration of all the different other types of technology that we wanted to include in this platform, as well as things like questionnaires, etc. And also the decentralized recruitment efforts was one of the main cost drivers of total costs. Not shown here, we also extrapolated results to a hypothetical what if we did have larger recruitment numbers. And there we saw that a main cost driver were the direct-to-patient shipments. So overall, we saw that introducing decentralized trial elements is associated with higher trial costs. However, out of the interviews that we performed with several members, stakeholders within this consortium, there are some expected ways that we think costs will be lower in the future. And I will highlight two of them. One of them is the expectation that when you reduce, reuse, and recycle technology, costs will be lower. Not just because you do not have to develop all of it all over from scratch, but also because complexity will likely go down through that, which also reduces training costs for sites and participants. This also means there will be a learning curve. As was mentioned earlier today, if we get to a point where decentralized elements are the new normal, people will be more easily using the elements, not just participants, but also site and trial personnel, which we expect will reduce costs. We also heard today that using patient perspectives is really important. And we also want to stress that we do not want you to only look at costs, but look at the costs in relation to the added value of certain DCT elements. And specifically, I want to talk about enrollment and retention here briefly. If these elements are of a lot of added value for certain patient population, the benefits that you see in enrollment and retention could outweigh some of the costs you make otherwise. And also, trial size can be relevant to think about when you think about trial costs in relation to DCT elements. Certain elements are associated with really high upfront costs, such as the development of a certain platform or trial. But this platform could be used in several trials, maybe later on, the reduce, reuse, and recycle, and not just different trials, but also for a lot of different participants. And there are other elements, such as the direct-to-patient shipments, which I talked about. These costs will increase when patient numbers go up. And so you not just look at these costs by themselves, but also what do these bring in added value to your target population. Thank you.